How can you use AI in your clinical practice aside from a scribe? How can we use it for our patients struggling with mental health issues? Stay tuned and find out from Dr. Tristan Gorrindo. He's the CEO of Forza Behavioral Consulting, where he advises health systems, payers, and organizations on behavioral health transformation, including value-based care, integrated delivery models, and digital innovation. He previously served as the Chief Medical Officer of Optum Behavioral Care, leading one of the nation's largest behavioral health platforms. A board-certified child and adolescent psychiatrist, Dr. Gorrindo has authored over 25 publications, delivered 100-plus national presentations, and remains active in national policy and clinical practice. You're listening to Succeed in Medicine, the show for practicing physicians who want to master the parts of their career and life that med school never prepared us for. From interpersonal skills to career navigation to the essential information every physician needs. I'm Dr. Bradley Block, and in every episode, we bring you brass tacks advice and immediately applicable insights from world-class experts, so you can feel prepared wherever your MD takes you and build a life in medicine that's sustainable, rewarding, and actually worth all those years of sacrifice. Dr. Tristan Gorrindo, thank you so much for being on the podcast.
Great to be here. Really excited to talk about AI and behavioral health. Super innovative and exciting topic.
Exactly. So tell us, right off the bat, is ChatGPT going to replace our therapist? They're already helping our radiologists. They are helping us in so many ways. They're writing our notes for us. So is the next step that AI is going to replace our therapists?
I don't think it's going to be as simple as replacing our therapists. When we think about patients, we think about the worried well, people who need a little bit of support, a little bit of coaching, and there might be a really important role for AI in helping those folks. But when we get into patients, people with mental illness, they really need somebody who's fully trained in all the modalities of psychotherapy and behavioral health treatment. One of the things that we think about when we're engaged in treating a patient in the behavioral health realm is not just about the words that we say back and forth, but it's how we say them, the environment in which we say them. And this boils out all the way down into neurobiology, right? There's something called mirror neurons that get activated when you and your therapist are engaged in this highly resonant conversation. And it's going to be really hard for ChatGPT to stimulate and activate those same parts of the brain as you would in talking to a real person. I think there's ways which can help people with mild symptoms. We can decompress some of the system in terms of creating more access. But I think therapists are here to stay. Will ChatGPT be able to help our therapists? Maybe, but that's to be determined.
But can't you program this type of stuff, right? You can program mirroring their facial expressions so they trust you more. You can program more empathy, less empathy, more inflection in your voice, less inflection in your voice. Like you can, we're not far from being able to make the person's face an amalgam of a bunch of people they know so that the features look familiar, but not identical to anyone in particular. Like, I feel like this is all programmable.
Maybe one day we'll get there. Yeah. And I think probably across society, we'll have this same kind of interactions with avatars driven by AI that will be indistinguishable from humans. But that's really the level that this technology will have to get to. In some sort of weird twist of fate in history, it turns out one of the first uses of natural language processing was actually a virtual therapist that was created at MIT in the mid-1960s. And so there was this computer-based therapist called Eliza that engaged in Rogerian therapy, was very reflective, say back to the patient in a different way, the thing that they had said to you. And 50 years later, 60 years later, it really hasn't taken off, right? We could just replace a human with a computer. We may have seen some movement on this in the last 60 years. So in the next 60 years, yeah, maybe we'll get there. But I think today there's still a lot of unconscious assessment that happens between a therapist and a patient that is going to be really hard for AI to replace for those with real mental illness, for those who are deep in depression, for those who are having a manic episode, for those who are on the edge of psychosis. There's a lot of nonverbal cueing that the therapist also uses as part of the assessment.
Yeah. It's interesting the way that you describe the difference in pathologies, right? Which for the listeners, we see them all the time in our office, right? They come in with these aches and pains. They're not a big deal. Most of them are self-limited. we get in trouble online because there are these patients that are like, I've seen 5 different doctors and they all said I was fine. And it turns out I had this thing. Of course, that individual's experience doesn't take into account that we see so many patients every day who actually respond really well to the reassurance and they are fine. But they're playing with the edges. Then maybe they have a little bit of anxiety. Maybe they do have a little bit of depression. But as you're saying, like, for instance, getting a child psych appointment in one of the area hospitals with me, in speaking to the chair of the department, he goes, we are seeing children with suicidal ideation daily that aren't able to get appointments for months. The kids that are struggling in other ways, you have to triage this stuff. These kids aren't less important, but their issues are less urgent. And I would think it's similar with the adults. There are lots of people with major pathology, psychopathology, and then the people who are struggling and could benefit from it, but don't have the same need. And is what you're saying that there are modalities that are available to them now that we can direct them to?
When we look at primary care, for as an example, our primary care physicians tell us that approximately 50% of visits have some sort of behavioral health component.
Yeah.
And so we don't think about 50% of our patients walking around at any one time with what we would call an axis 1 mental health disorder, right?
Yeah.
One of these kind of major diagnoses. But we know every day that our patients are struggling with grief, with relationship problems with their spouse, with parenting challenges. I think those are the kinds of things that we are more amenable in this kind of coaching way to helping parents. And I think that, or helping parents in the case of child psychiatry, or patients more generally in the case of adults. And I think we're starting to see tools come online, particularly in that kind of coaching lens, that I think will be really helpful for those subclinical, but still very important things that cause people to suffer in their lives and to really stress them out or keep them from working well or doing well in their day-to-day function.
That's interesting that you mentioned it as coaching, because we've had a lot of coaches on the show. There are a lot of physicians out there, a lot of listeners who are coaches. And I feel like it's skirting that line. Like, you were trained as a urologist and then you took some courses in coaching and now you've basically become like therapy light. So I'm not trying to denigrate anything that they do, because there's a role for it and there's a benefit for it. And it sounds like what you're saying is that's actually great, because that frees up our therapists to take care of the people who have suicidal ideation or have breaks from reality with schizophrenia, the people that are suffering a lot more.
Yeah, very few of us went into medical school because we just wanted to work on one small part of the body. I'm a right-hand surgeon and I don't care about the entire rest of the human.
I don't know. I'm an otolaryngologist and there are otologists. They're just ears. Just ears. Rhinologists, they're just noses, as if ear, nose, and throat wasn't specialized enough. I'm not sure that's true, but continue.
But yeah, I think that most of us went into medicine because we care about people. And
the whole person. The whole person.
It's hard to divorce the right ear or the left hand from the human condition, which I think people suffer from in your offices. And we're humans. We want to help people. And I think when you reference ENTs going and becoming coaches, I think it's really a desire to the part of the physician to say, how do I help take better care of the whole person? I think that's really what they're doing, and having a broader skill set. And I think that's the heart of what medical behavioral integration is about, right? It's about how do we think about the whole person, their physical and their mental health needs all together as one.
Personally, that's what I find the most mentally taxing. The medicine at this point, I've been practicing for long enough. The medicine is usually pretty straightforward, and it is just fitting the medicine within the psychosocial context of where that person is, often the challenging. Not every time, but sometimes it can be the more mentally taxing component. So I'm still not sure where AI fits in right now for us. Wow. Is there any way that we could leverage it now for those patients, a direction that we can point them in?
I don't think it's ready for prime time.
Okay.
We've heard anecdotal stories about patients who are engaged in discussions with ChatGPT about problems in their marriage, and it's been really helpful. Or folks that have been engaging with Gemini around their symptoms and trying to engage in some sort of behavioral scheduling. And those things are great. And when they work, and that's wonderful. But as clinicians, as physicians, when we recommend a treatment, we really need to be pretty certain that there's a fidelity there to the outcome, and that if bad things are going to happen, that there's a safety net there to catch that patient and take them to the next level of care, whatever that next level of care may be. And a lot of the companies have skirted around this and looked for key phrases, key buzzwords, those kinds of things that indicate safety risk and say, call 988, go to the nearest emergency room. But that's probably not sufficient in terms of what we would want in terms of a treatment that we would recommend to our patients. So I think it's coming. I think we're going to get there very soon, but I think it's not quite ready for prime time just yet.
Because there have been some untoward outcomes. You mentioned that there was an article in the Wall Street Journal?
In the Wall Street Journal, yeah.
And then I've heard of people that have gone down the rabbit hole. If you ask ChatGPT, should I join a cult? It'll be like, great, yes, let me give you some fantastic options. So there's an element of judgment there that it just doesn't have. Because I guess it's not supposed to judge. It's just supposed to answer. And so what are some of the things that you've heard? And what's real?
One of the things within all the AI platforms that they're really trying to understand is how much, and there's a dial essentially that they can, a digital dial, that they can more or less titrate. How much do we want the agent to align and be helpful to the person, the patient in this case, using the platform versus pushing back? And so in the case of this Wall Street Journal article that was published last weekend, there was a patient who had some really grandiose delusions, right? On the verge of psychosis. And at least as reported, the AI platform that this person was interacting with was basically saying, yeah, you do have special powers. Yeah, you are able to bend time or whatever the delusion was. And that only reinforced some of the psychopathology. Ultimately, the patient ended up on an inpatient unit, got the treatment they needed. But it's an example of the 1% or the 5% of edge cases where the platform doesn't handle it correctly. And I don't think we as physicians, as a medical community, are willing to tolerate that much inaccuracy in our treatments. And so we're just not there yet.
No, certainly not. If we're not able to tolerate the side effects of a 1 in 10,000 or 1 in 100,000 complication of a vaccine, certainly we're not going to tolerate this type of, it's just that the fact that it goes off the rails so easily. Okay, so if that's where we are right now, then how is it going to augment therapists? Because I still don't quite understand how therapists can utilize it in a therapy specific way. Like I can understand using it to answer questions the same way. What are the best, if I'm going to be in Southern California, what is the best beach for me if this is my requirement? Therapy specific.
Yeah. So one of the things that there are a number of companies working on is this idea of therapy augmentation using AI. And so what that means is, for example, one of the most common forms of therapy is something called cognitive behavioral therapy, right? This is this idea of helping people apply certain types of cognitive skills and situations to think in a more positive way. And so there are some platforms out there that are being developed that essentially in the therapy session, when you would normally, the therapist would be teaching the skills to the patient, they essentially bring the AI in as a tutor to actually teach the skills to the patient under the therapist's supervision. And this is pretty cool, actually, because in behavioral health, we actually don't know what is happening inside those therapy sessions for the most part, right? Therapists are trained, they're doing cognitive behavioral therapy, but there's not a supervisor sitting in there listening, observing what is actually happening in those sessions. And so when I was a CMO, I had 3,000 behavioral health clinicians working under me. I had a sense that people were qualified to do the work, but I had very little understanding of what the individual session was happening. And if I knew that they were using some sort of standardized approach, if they were using an AI tool that was driven towards the fidelity of the model, and we could guarantee that they were teaching these 5 skills in exactly the same way every time, that would make my life as a CMO much less stressful because I would have a much better understanding of what is actually happening in the treatment.
So the way I'm envisioning it is you have a therapist who maybe has 3 different exam rooms and they set one patient up with the chat GPT, all right, this is a lot of initials, a lot of acronyms now.
Cognitive
CB,
behavioral
CBT, GPT, CBT is what we're saying, right? Cognitive behavioral therapy. Cognitive behavioral therapy in one room. And then you go to the next room and you set them up. You go to the first room, you check in on them, see how everything's going, make sure it's not going off the rails. Then you go to the second room and it frees up some time and cognitive load from the therapist to be able to treat multiple people at a time. If you like this podcast episode, you're going to love the other shows over at the Doctor Podcast Network. For instance, Luxury Cruising. You know that moment? Sipping champagne, watching the sunset from your private balcony suite? Yeah, that's the magic of luxury cruising. Dr. Crystal Seditis takes you there on Luxury Cruising, explore the world in style. From the most opulent ships to insider secrets on upgrades, she's your guide to traveling first class at sea. If you're dreaming of your next escape, this is the podcast for you. Search Luxury Cruising and subscribe. Your suite awaits.
You know, a lot of the payer requirements, I don't know if they're ready to accept this idea of concurrent sessions from a billing framework. But I think you did hit on something really important, which is that during that time, a therapist has the ability to catch up on their documentation, to catch up on their process notes, to listen. Sometimes it's hard for us to really hear what's being said when we're in the middle of the conversation. Sometimes standing back and listening to the conversation gives you a different perspective. It's interesting. The average therapist in this country, I think a lot of physicians would be surprised to hear this. A full-time therapist sees 26 to 28 clinical hours a week of care, leaving 12 hours a week to do all the documentation, the follow-up, the coordination of care.
Every physician would believe that because it could be similar, right?
Yeah. And the idea is if you make the session more efficient, can you now essentially reduce the burnout on our clinicians?
Yeah.
Can you create a little bit more expectation around clinical productivity and ask people to see one or two more patients? And would that actually be a good thing for the system as a whole?
Yeah, that's interesting. We're going to be talking about in a moment AI for clinical documentation for all physicians. It has been great in terms of freeing up our cognitive energy. So I don't have to sit there documenting and I can actually be there in the moment with the patient engaging. And so it sounds like it's the same thing for them, right? I'm able to get home faster if I'm using my AI clinical documentation tool. But before we move on to that, I just want to make sure that there's nothing else that we need to discuss in terms of AI and behavioral health. Are you using that interchangeably with mental health?
Yeah. Interestingly, behavioral health ends up being the broader umbrella term, which encompasses people with what we consider traditional mental health diagnoses, as well as substance use disorders. Sometimes substance use disorders are not considered part of mental health. And I think particularly when it comes to substance use disorders, I think there's a lot of interesting, exciting things happening around, can you use AI when people are most vulnerable for relapse to check in with them, to reach out to them, to connect them with therapists, to measure cravings? Within that behavioral health sphere, substance use disorders may be one of the places where we see broad adoption of AI rather quickly, because it's really well suited for being in a patient's pocket and popping up just in time.
Yeah. Wow, that'd be amazing. Okay, so let's go down the other pathway, which is AI for all physicians, right? Not just behavioral health, but for all physicians. And so we got into, and if the listener wants to hear more about clinical documentation and AI scribe, we've had Heidi Health that have sponsored the show. They have an interview. We've had Freed AI. They've sponsored the show. They've got 2 interviews. So and they're great. They're great. But let's talk about some other things. How else are you using AI in your private practice, aside from the documentation?
First, in full disclosure, I'll say I am a convert. So I recently switched to using a scribe in my psychiatry practice. I'm a child psychiatrist, and it has been a game changer in terms of my ability to be present with the patient, engage with them, and have the AI keeping track of what's going on in the session. And the thing I think I was most surprised by is that how affordable it is, right? I think there are these big solutions out there that are hundreds of dollars a month, those kinds of things. But there are a lot of AI first companies out there, and there are many others, where it is not, even for clinicians who are practicing part-time, it's just much more accessible than you could ever imagine in terms of adding it to your practice.
Yes. So we're all believers. But when we were before the show, you were talking about all these other ways that you're using it in your practice that I didn't know were options. So you said prior authorizations. How are you using it for prior authorizations?
So one thing I would encourage all your listeners to, and I'm not going to plug a lot of platforms, but I will plug one, is go take a look at Open Evidence. So this is a platform that was stood up by New England Journal, JAMA, Mayo, and think about it as a ChatGTP for clinicians. You have to have an NPI to register for it. They give you CME credit for engaging with it. But one of the things that it'll do is that if you're discussing a patient with the platform, it can help you write prior authorization letters. It can help you write appeal letters. It can help you write school letters. It can help you do a lot of the things that just eat up a lot of our outside of clinical time, where you know it's the right thing to do for your patient to get them their disability review or whatever the thing may be. But this is one of the platforms that's just truly been so helpful, in addition to being a AI agent that can just pull back search results that are all evidence-based, right? So it uses PubMed and other trusted resources for answering your questions, essentially.
So can it guide in diagnosis and treatment?
Yeah. So like the kinds of questions that I was asking it yesterday, for example, I was in clinic last night, right? And I needed to cross-taper a patient from sertraline to desbenlifexine, right? There's just no easy answer as to how you do that. But you go and then you ask it, how would I cross-taper a patient from sertraline Zoloft to desbenlifexine Prestige? And like, it will tell you what the evidence is available and isn't, what the starting doses are, what the half-lives are, and package it up in the way you would expect like a ChatGTP to package it up. And so it's a pretty powerful tool. And sometimes we as clinicians, we get questions that are a little bit lane adjacent, right? So as a psychiatrist, I'll get questions around primary care lab abnormalities, things that I haven't thought about since medical school. And it's like a great way to boot back up and then see, is this related to the disorder that we're talking about here today?
CBC is totally normal. The mean cell volume, a little bit elevated.
And the thing is, you can use many of these platforms for doing this kind of work, right? I've used them in other cases where I've taken complex neuropsych reports that are sometimes 30 pages long. And the patient's on my schedule, they're about to walk in the room. I've got this 30-page document that the patient wanted to read. And I can get a synopsis of it real quick. What are the key points that I want to pull up?
Wait, what platform is going to be HIPAA compliant for something like that?
So this is the trick. You have to find a platform that has a BA that will create a BAA with you. BAA is the business associate agreement. That's the requirement under HIPAA, which basically says that they're going to handle your information in a way that's going to be HIPAA compliant. And so OpenAI, as part of the sign up, if you have certain paid versions of Google Workspace plans, you can opt in to have a BAA created, and then you can use it as a HIPAA secure space where you can put patient information and you can use Gemini.
Wait, hold on. ChatGTP is OpenAI.
Yes. Gemini is Google.
But you said there's this BAA. All the searches that I've done are saved. So how do I have to go and manually destroy my results? Is that what you're saying?
So Chat in OpenAI, no BAA. Don't put patient information there.
Got it. Okay.
Gemini, Google.
Yeah.
And certain Google Workspace plans, you can get a BA generated through the platform. You request it, essentially. And in that process, they basically put you in a kind of a certain category, right?
Yes.
So they turn off experimental features. They have a different kind of retention policy, just as you were alluding to, Brad, around how long those chats persist. Those are all configurable once you activate the BAA. So I don't want any of your listeners thinking they can just go and take, oh, my patient was discharged from the hospital, I'm going to go and upload it to XYZ AI platform. That is wrong. Do not do that. Do not take that away. But if you're using a platform for which you have a BAA, that is totally acceptable and permissible under HIPAA.
Just to clarify, I thought I had heard you say earlier that OpenAI, you can get a BAA.
OpenAI, you cannot. I did not misspoke.
Okay. That's
Gemini,
interesting.
Google, you can.
because I do expert witness work where I will be taking notes as I'm speaking to someone. And so what I can do at the end is if I use Gemini, I can then upload that into Gemini and say, can you please make this a little more full sentences and a little more coherent? And then it'll do that step of work for me.
If you have
BAA. Got it. Okay.
So that's the important part. And I think the other thing you're reminding me of when you're using it for a specific task, like all of these platforms, they remind me of having a medical student or a resident working with you, right? Like they're brand new and like they have some medical training and they're like able to write down information or get history basically by listening to the patient's story. But it's not the way in which you would think about it or you'd present it.
Yeah.
And if you really want to go down a rabbit hole, which is super interesting to me, around prompt engineering, it's how you teach your Gemini agent or your ChatGPT agent, whatever the case may be, to think more like you do, to respond more like you do, to write up your reports more like you do.
Yeah.
And a lot of these AI scribe platforms had the ability to customize them through this, what we call prompt engineering, to generate notes that actually look and sound much more like you look and sound when you write your own notes. So it's not a kind of an all or nothing thing. There's a negotiation that happens between you and the platform to teach it like you would a medical student or a resident to work in the way that you do.
So I have used a couple of different AI scribes. Some of them do, and some of them don't. Or some of them, it's so clunky. Like they have one that you have to interact with it on your phone. And so if you're going to train it, you have to be using it on your phone, which the optics of which are terrible. I don't want to be picking up my phone. So even though it uses the mic from my phone to listen to the patients, and that's fine. So that the phone has to be in the room and has to be on. You have to disclose it to the patient that is listening. Fine. But like for me to pick up my phone and be like, the optics are awful. Like I only want to be at my laptop rather if I'm going to be training it. And actually the training's been great for my podcast. I use it to come up with suggested podcast titles. And then I'll say, this was the final title that I chose. Please put it in your memory for future titles. I use it to help me write questions. And then I'll put in my final question list. This is the final list of questions that I'm sending to the person that we discussed, just so you can make future questions more like in my voice. And so you're training it to be more like you. So here's my fear, because we're using these things and they're learning from us, right? Is the AI going to learn enough from our clinical decision-making that it will be replacing us? Are the people that are writing these programs then using the medical decision-making that's happening in the exam room to then teach the AI the medical decision-making so that then we can be replaced?
Yeah. And I don't know. We'll see. The speed at which AI has progressed over the last 3 years, it's really hard to imagine what 3 years from now will look like.
I think the malpractice attorneys will make sure that doesn't happen because the programmers are going to want nothing to do with that.
At the end of the day, they're still going to need someone to sue, though.
Yeah,
and
that's
so,
what I'm saying.
So physicians, I think we're probably pretty well placed to whatever happens in the AI revolution, we will still exist. I think lawyers are in a similar place. But there will probably be some displacement of folks that work under physicians that are doing more of the kind of mechanical pieces of clinical judgment and those kinds of things. We are starting to see it. Some of the big EMR platforms, right? AI is now responding to clinical inbox messages or drafting responses and all those kinds of things. I think physicians are probably okay for a while.
Who answers your phone? Do you have AI answering your phone yet?
No, not yet.
Okay.
In the group practice where I work, we have a front desk. In most of behavioral health, interestingly, over half of behavioral health clinicians are still single shingle, doc in a box. They have no front desk staff. They're maybe on an EMR so that they can have e-prescribing. They do all their scheduling manually. That part of the behavioral health segment is primed for basically having an AI agent take over the front desk staff. And that could be scheduling, that could be RCM, the claims submission, all those kinds of things. I think we'll see a lot of advancement there because behavioral in particular is just way behind.
And right now we have got a robot answering the phone, right? That could very easily be replaced by an AI that's like, how can I help you today? And some places are already doing it. What language would you prefer? And then how can I help you? And then at least that step is taken over by AI and directs you towards a human person.
Yeah.
But I'm sure that's very quickly going to go completely AI.
Yeah. And I know a health system in Pennsylvania, for example, that is using, prior to your first behavioral health appointment, you meet with an avatar, and the avatar collects a lot of basic information, a lot of basic history. But if the avatar senses that English is not your first language, that it might be Spanish or something else, it will flip into the native language of the patient and just pick up where they left off and continue forward. And then the note that goes to the clinician in preparation for the first visit is, of course, all in English, because the AI has then transcribed it and summarized it in the clinician's language. So that's already happening.
The way you're describing that, it sounds like we could do history of present illness with AI, right? You have the person answering the questions, and then it's like, it leads to another question, which leads to another question. And then it gets presented to us as a chronological series of events, which is not how we hear it initially, right? You've got to often prompt the patient many times to get it in a way that we can process it more easily. And so it sounds like AI can then take that part of the history. But as we've talked about on the show many times before, a lot of the purpose of history taking is not just to get the information. Many times, you know what the diagnosis is when you walk in the room. It's for trust building. And so then you're removing yourself from the critical trust. All right, I've just talked myself out of using AI.
And that's, all that time you normally would have spent talking about family history, my great uncle Joe who had blah, blah, blah. Unless the AI is collecting that, and you can now spend the entire appointment connecting with the patient eyeball to eyeball and really hearing their story in a deep way, the AI may have actually enhanced your ability to connect with that patient.
Oh man. So you're telling me 3 weeks ago, so like before the ambulance picked you up, you were lying down on your kitchen floor and the room was spinning around you. Oh, that just sounds awful, right? Oh, tell me what was going through your mind at that time. Like, meanwhile, I know they have vestibular neuritis, right? I know what the diagnosis is. I know but now I'm able to spend that time, as you said, building trust with the person, connecting with them. And
when we do intakes, for example, the payers want us to check a number of boxes, or CMS wants us to check a number of boxes in order to meet the criteria for a CPT code. We've got to ask all the review assistance questions. We've got to ask the family history, the social history, the medication history, all these kinds of things. Those things may or may not be germane to the issue that you really want to focus on with that patient, but they're a requirement of the visit. And so if you can have somebody else helping you with that, right?
yeah,
this is what we used to have our medical students help us do. Then why not leverage them to do that so that you can have a better appointment with the patient?
If our listeners want to learn more about you, they want to learn about how you're using AI in your clinical practice, they want to read a lot of what you've written. I know you also talk about digital navigators. We didn't get into that at all. So if the listeners want to learn more, where do they find you?
Find me on LinkedIn. It's probably the best place. I tend to post a lot of things that I find interesting related to this topic. And if you just want to search on LinkedIn, Tristan Gorrindo, or LinkedIn/in/Tristan, you'll find me.
Fantastic. Dr. Tristan Gorrindo, thank you so much for your time and all you do for your patients and your fellow physicians.
Real pleasure, Brian.
Thanks for listening. I have a favor to ask. You listened to the episode until the end, which means either you fell asleep or you really liked the episode. So please write us a 5-star review, take a screenshot, and email it to me so I can send you a quick guide on how to earn patient trust in 20 seconds or less. Email me at brad@physiciansguidetodoctoring.com and feel free to suggest a topic or guest. I take your requests seriously. The views expressed on this episode are those of the interviewer and the interviewee and do not represent the views of their employer or even their significant other. Even though the magic of podcasting makes it sound like I'm talking directly to you, this is not a doctor-patient relationship, and this is not medical advice or financial advice or legal advice or really any advice. Thanks again for listening to Succeed in Medicine.